Endoscopic management of active arterial bleeding and walled-off necrosis collection. These are our authors, and these are our relevant disclosures. A 45-year-old female presented with acute necrotizing pancreatitis secondary to alcohol use. 23 days after initial presentation, the patient developed recurrent abdominal pain and underwent computed tomography, or CT, with IV contrast of the abdomen and pelvis that showed a large 15-centimeter encapsulated collection consistent with walled-off necrosis. As the patient was symptomatic from the collection and it appeared walled off on imaging, the patient underwent endoscopic ultrasound, or EUS, guided cystgastrostomy with placement of a 20 mm by 10 mm lumen opposing metal stent, or LAMS, and placement of a 10 French by 4 cm double pigtail plastic stent across the LAMS with no complications. There were no large vessels visualized within the walled off necrosis cavity on EUS with Doppler. The patient presented to the emergency room 6 days later with hematemesis. CTA performed twice within 24 hours showed echogenic material in the walled-off collection consistent with blood products, but did not demonstrate active bleeding or pseudoaneurysm. Due to this continued intermittent bleeding, and after multidisciplinary discussion with surgery and interventional radiology, the decision was made to proceed with endoscopic evaluation and therapy. During EGD, the previously placed plastic double pigtail stent was removed and the single-channel therapeutic gastroscope was advanced across the cystgastrostomy site into the walled-off necrosis cavity. It was filled with large amounts of clot and red blood. Extensive clot extraction was done with a raptor grasping device and snare, requiring multiple intubations of the cyst. Initially, no active bleeding or source of bleeding was identified. To rule out bleeding related to LAMS-induced vascular injury to the opposite wall and to prevent further mechanical injury, the LAMS was removed using a grasper forceps. No bleeding was noted behind the LAMS or the opposing wall. Thus, the endoscopic necrosectomy and clot removal was continued. After a total of 30 minutes of necrosectomy and clot removal, active bleeding from a pulsatile vessel coursing through the collection was noted away from the cystgastrostomy site. Initial attempts at hemostasis using coagulation grasper forceps were only partially successful. To ligate the vessel on both sides, hemostatic clips were placed on either side of the vessel as it coursed through the walled-off necrosis cavity perpendicular to the vessel's direction to ensure appropriate hemostasis. Immediate blanching was noted after clips were placed. Through the scope, 16 mm clips were used as their grasper apposition will give a tight seal. Placing clips extraluminally was discussed with surgery. This was followed by monopolar thermal therapy with the coagulation grasper forceps. Hemostasis was successfully achieved, and cessation of pulsation of the vessel was observed. Further clips were placed, a total of 5 throughout the procedure. Ligating this large vessel was also discussed with surgery during the endoscopy, and it was deemed that the benefits outweighed the risks of ligating a large vessel in the setting of active bleeding. To maintain hemostasis, a self-assembling matrix gel was chosen given its ease of application to keep the visibility clear, although other agents such as hemostatic sprays were considered. Finally, pigtail stents were placed across the lumen. The patient underwent repeat EGD with necrosectomy 1 week later that showed no active bleeding or clots in the residual walled-off necrosis cavity with healthy appearing granulation tissue on the walls. A few red spots were seen and were treated with bipolar thermal therapy as well as peptide matrix gel. The decision was made to not remove the clips. Patient did well and had no further episodes of bleeding and had resolution of symptoms. Follow-up CT 6 weeks later showed resolution of the walled-off necrosis cavity with clips in place. 3 clips were still noted on follow-up imaging 6 weeks and 10 months later, but patient continues to be symptom-free. Spontaneous passage of the cystgastrostomy stents was noted. Bleeding during drainage of walled-off necrosis and subsequent endoscopic necrosectomies is a known complication and occurs due to various etiologies including direct injury of vessels during placement of LAMS, pseudoaneurysm formation, and less commonly injury to vessels when the wall of the cavity collapses against the LAMS. Delayed bleeding from spontaneous erosion is less common, but possible. Our case was likely secondary to spontaneous erosion of a branch of the splenic artery or the left gastric artery. Bleeding post-LAMS is usually managed by interventional radiology, particularly in cases related to splenic artery pseudoaneurysms. However, endoscopic therapy should be considered in cases where imaging does not reveal active arterial extravasation or bleeding is intermittent in nature. If endoscopic therapy is pursued, careful inspection of the LAMS site with removal of clots to identify possible sources of bleeding is crucial. This case portrays successful endoscopic therapy for bleeding within a walled-off necrosis cavity using through-the-scope clips, thermal therapy, and fibrin gel matrix.